Terrific. Well, thanks very much for the invite to present again. I'm happy to talk about things. And I think hopefully I've left enough time at the end for some questions as we go along. Soroush asked me to do a very difficult thing, which is to do a joint injection aspiration workshop virtually. So hope you've all got your needles and an unsuspecting person sitting next to you that you can practice on as we go. There we go. So I have no disclosures that are relevant to this talk other than perhaps that at this stage in my career, needles are the only sharp objects I'm allowed to hold in the clinic, certainly after the incident, which we won't talk about. These are the learning objectives. And we're going to talk a little bit about some of the background around things. Well, I'll show you a few practical tips and then some surface landmarks and some resources. Honestly, a lot of these procedures are very straightforward to look up online, and there's lots of videos that you can watch to see when you need to do them. So I've broken this into the rules of joint injection and aspiration. And in the spirit of David Letterman's top 10, we're going to start with the least important and work our way up. So rule number 5 is that joint aspiration can be very helpful in making a diagnosis sometimes. All right, and I'll go through what I mean by that. So what can we tell from synovial fluid? So if you're lucky enough to have a big fat swollen knee in front of you and you manage to get a bunch of fluid out of it, first thing you can do is look at it. Ontario actually has a billing code for holding it up to the light and taking a look at it. And you can see these test tubes here range from very clear, normal, to a bloody tap. You can see that the non-inflammatory that you would see in osteoarthritis is kind of a light straw-colored fluid that you can read a paper through. The inflammatory is cloudier and you can't really see through it very well. And then there's purulent from just frank pus. And then if there was a bloody tap. I want to point out that normal synovial fluid is very clear. And this is probably a tube with just water in it because even a knee has only about a cc of synovial fluid normally. So you're not going to be able to aspirate normal synovial fluid in a knee or any other joint for that matter. The other thing you can sometimes see is these little floaties that occur. These are particularly seen in patients with rheumatoid arthritis who come in with a big joint and you go, you're not quite sure what that is. These are called rice bodies. They're little bits of infarcted synovium. So if you remember in rheumatoid arthritis, the delicate lining tissue called synovium becomes very enlarged. It outstrips its blood supply. And these things can be hanging around and make it look almost like it's purulent, but it's not really. Now, if you do get fluid and you've got a tube there, there's lots of things you can send it for, but you only have to remember the 3 C's: cell count, crystals, and culture. And we'll sort of go through those. So the first is the cell count is going to tell you whether it's inflammatory or not. And there's lots of tables out there on UpToDate and other resources that tell you that if it's 75 to 100,000, it's probably septic. If it's 50 to 75, it's probably crystal and all the rest. But there's so much overlap between those numbers that they're not particularly helpful. So here's the numbers that you need to know. 200 or less is normal. Non-inflammatory arthritis is anywhere between 200 and 2,000, so that's osteoarthritis. And if there's 2,000 or more, it's definitely inflammatory. Now, you can have rheumatoid arthritis with less than 2,000, but you know that if it is 2,000 or more, it is inflammatory. Now, for most of the conditions that we aspirate joints, inflammatory arthritis, septic arthritis, crystals, the high cell counts are usually PMNs, but if it's a resolving inflammation, resolving effusion, that it tends to become less PMN predominant and have more monocytes or lymphocytes. Or if it's an atypical infection like TB or fungus, it may be more monocytic or lymphocytic in nature. But what you're mostly going to see for the vast majority of the patients that you do this on would be PMNs. So if you do get cream of tomato or cream of mushroom soup in this kind of a case here, that's almost always septic until proven otherwise. It doesn't have to be. If you have very high cell counts of 100,000 or more, it's more likely to be septic. But we've certainly seen that even in rheumatoid arthritis or in some other ones where there's been cell counts close to 1 million and still not been septic in that case. Cultures may be negative if the antibiotics are given ahead of time, which makes this a particularly useful talk for all of you who work in resource poor areas where you may want to try and aspirate the joint before you send the patient out or give them antibiotics, particularly if they're not particularly well. Couple of things that are not easily grown from joints. One is gonococcus. You only get about a 50% yield from a gonococcal arthritis. So always a good idea to do like the bank robbers and go where the money is. So you'd send a urine for nucleic acid amplification if you're considering gonococcal as one of your differential. And TB usually doesn't grow from synovial fluid. You actually need a synovial biopsy. So you need to find a orthopedic surgeon somewhere who will do that. It doesn't mean that it's not worth looking for. It's just much harder to get out of the joints. So apart from cell counts and culture, you can also do crystals. And you can send these away for polarizing microscopy, usually done in the hematology lab. Most medium to larger hospitals will be able to do this for you. Um, and what you can see is that the crystals that are present in the fluid refract light as they go through and change the color. So all the crystals oriented here with uric acid in one direction are yellow and in the opposite direction are blue. You can change that just by flipping the filters on your microscope so that they all the ones going in this direction are yellow and all the ones going in this direction are blue. And every microscope that does this will have a little control slide next to it as it to be able to tell you which is uric acid and which isn't as you go. You can see calcium pyrophosphate crystals are much less impressive than the uric acid crystals. They're also harder to find. So if you're very concerned about CPPD, the sample that gets sent at 2 in the morning to the lab or looked at by the clerk or the lab tech in the middle of the night, who's less experienced, may not give you any crystals at all. And these were taken on the same microscope, and you can see that they actually have different orientations because one is positively birefringent and the other is negative. The lab in Manitoba used to just report them as positively or negatively birefringent, but now they actually identify the crystals for you, which makes life a lot easier. Now, this last picture on this slide is actually a uric acid crystal that has been phagocytosed. And so the lab will also comment on whether this uric acid or CPPD crystals are intra or extracellular. If you have a patient who has very high uric acid levels and has a different cause for their inflammation in their joint, they may have uric acid crystals hanging out that are not intracellular, they're extracellular, and they may just be bystanders. When you see there are intracellular uric acid crystals, that tells you that the immune cells have phagocytosed the crystals And that's when they can activate the NALP3 inflammasomes, which causes all of the inflammation. So intracellular crystals are likely to be the ones that are pathogenic in that setting. Okay, so when is a joint aspirate useful, right? So when I was training, my mentor told me that anytime you think about it, you should stick a needle in a joint. That's a reasonable thing to think about, but in a difficult situation where your patient's screaming and yelling and maybe you don't want to do it, it's when is this going to be most helpful for you? So if you've got a case who's like a 45-year-old guy who's got a little bit of kidney failure, maybe some IV drug use, and he presents with a red hot knee and a low-grade fever, then this is an opportunity where your differential diagnosis is, well, this could be septic. He's an IV drug user. He's got a low-grade fever. Could be a crystal arthritis because he's got some kidney insufficiency. So maybe he's got some gout. You can get a low-grade fever with that. Or maybe it's a reactive arthritis, which can also give you a red hot joint. By the way, these three things are the differential diagnosis for a single red hot joint, which is really nice because I like things that only have three things in their differential. So this is a no-brainer. This is a very good time to pull out a big needle and to aspirate a joint because you're going to be able to distinguish whether it's septic, crystal, or just an inflammatory arthritis in this setting. And if you do it before you send the patient out, then once you have the fluid in hand, you can start giving them antibiotics if you have a concern for a septic joint. So here's another case, and sometimes we run into people who are feeling badly because they didn't do a joint aspirate or they couldn't get fluid out of a joint. So here's a 30-year-old woman. She's got 12 swollen, warm joints for the last month. None of them are red and hot. They're just warm and swollen. She's got prolonged morning stiffness. So in a setting like this, it's very unlikely to be septic because she would be much sicker. And it's very unlikely to be a crystal arthritis because she's a 30-year-old female. So we're thinking about things like rheumatoid arthritis, lupus, maybe viral. Because they're warm and they're swollen and she has lots of morning stiffness that this is an inflammatory arthritis. And you're not really going to find out that much more by doing a joint aspirate. You would expect your crystals to be negative and you'd expect your cultures to be negative. So in a case like this, it's not wrong to aspirate the joint. It's just not going to be very helpful. And you're probably better doing the 1,000 other things that you have to do to get this person looked after. Okay, that's rule number 5. Rule number 4 is that joint injections can be therapeutic. So there are a number of things that you can put into joints to make them better. If you do a joint aspiration, you're going to make the patient feel better for a short bit of time, but the fluid will almost always come back very quickly afterwards. So what are the things that we can put into joints? Well, we can put lidocaine in, we can put corticosteroids, we can put hyaluronic acid derivatives like Synvisc or Durolane, and then platelet-rich plasma and mesenchymal stem cells. We'll talk a little bit about these as we go. So when would you use just lidocaine or bupivacaine? Yeah, some musculoskeletal people will do this as a diagnostic test. So if you're not sure what's generating the pain, if you put in a very small amount of lidocaine into an area like a subacromial bursa, you can say, okay, I think this is the source of the pain. And then you can go ahead and do some more therapeutic kinds of things. Of course, lidocaine doesn't last very long. Bupivacaine does last for 24 hours. You just need to use a large volume. And so one of the reasons that we mix when we're doing steroid injections, we'll mix the steroids with some lidocaine is to give that immediate feedback that, okay, we probably got it in the right spot because the patient is now smiling and walking out of here and thinks you're a great doctor. Corticosteroids are probably the most common things that we inject into joints. They're inexpensive. They're readily available, except in nursing stations, but some have gotten them in. Um, and there's two different ones that we tend to use. One is triamcinolone. There's a couple of different types of triamcinolone. These are less soluble. And the reason that that's a good thing is if you're injecting it into a joint, it's going to stay in the joint. So it lasts longer in that area. It doesn't get diffused through the rest of the body. And it's less likely to cause systemic side effects like hyperglycemia. Methylprednisolone or dipomedrol is more soluble than triamcinolone, so it tends to cause less soft tissue atrophy if you happen to put it into a tendon or a tendon sheath or a rotator cuff. And so we tend to use this one for shoulders, but it has more systemic effects. Most of the time, if you're in a remote area, what you're going to have available for you is more likely to be methylprednisolone than triamcinolone. If you're sending your patients down to, sports medicine for their injections, they will often be offered things like hyaluronic acid and platelet-rich plasma, and sometimes even mesenchymal stem cell injections. Um, these are not currently recommended in terms of certainly hyaluronic acid, although it's given a lot. And the reason is that, well, I'll tell you a little bit about hyaluronic acid first. Of course, these are in patients who have osteoarthritis. Hyaluronic acid is a big molecule, and in OA, it tends to get broken down and it doesn't last very long, and the concentrations are lower. So we're basically, by putting it in the joint, changing the oil. A series of injections of Synvisc or Durolane is about $400, and it's not covered by NIHB. It's not covered by Manitoba Health. Some private insurance will be able to cover it. And they do use a lot of it in sports medicine to make people feel better. Plasma-rich or platelet-rich plasma is the other thing which is very popular these days. They take the patient's serum, they enrich it with platelets, and they inject it back into the patient's. It is obviously very complicated. It's expensive. It's not covered. And neither of these are currently recommended by bodies like the American Academy of Orthopedic Surgery or other agents because of their relative cost and the very poor data around their effectiveness. Most of the trials that have been done have a lot of bias and some heterogeneity and not particularly useful. Mesenchymal stem cells are yet another newer technique that are being utilized, and in some of the for-profit injection centers, they're all the rage. Again, I think in Canada for this point in time, they're largely should be experimental at this point. They may be very effective. Some of the preliminary data is there, but again, they're not covered and they're expensive. So um, I think one of the things that you can do as a provider, if you're seeing your patients, is to reassure them that they're not really missing out on great things if they decide to spend their money on something other than hyaluronic acid and platelet-rich plasma. This is, and I apologize because I pulled this slide from my undergraduate lectures that I put together much more than a decade ago, and I couldn't find the reference for it. But this was probably one of the better randomized trials done for a large hyaluronic acid molecule called Hyalgen. And this is in patients with osteoarthritis. And you can see that they reported a visual analog scale 0 to 100 is actually the scale that they used for how much pain they had. This was when they were screened, and then they were taken off of whatever NSAID or Tylenol that they were on. And this is where they flared. And then they were either given injections, sham injections, placebo or naproxen or placebo naproxen. And what you can see is that they went from a visual analog scale pain of, 5 out of 10 down to pain level of 2 out of 10 after, 6 weeks or so. But there's really very little visible difference between the two. When we get out to 26 weeks, there is a statistically significant difference between the placebo and the Hyalgan, but not a lot of clinically important difference in terms of what the MCID is for these therapies. And so it's on the basis of data like this that the hyaluronic acid derivatives are not really recommended. I think what's really important to note is the amount of a placebo effect with this injection. So if you look at making somebody feel that much better, even though they got a placebo injection and a placebo oral pill, that's pretty good. So I think and that's probably the one saving grace of those two procedures is that if people can afford PRP or hyaluronic acid derivatives, really what you're doing is treating pain. And so even if you just get a placebo response, it's probably not a big problem. This is also ripped off from myself. And I put this slide together from a number of different references, but it really shows the effect size of different therapies that we use for osteoarthritis. And you can see that intra-articular steroid injections have an effect size of about 0.7. Topical NSAIDs about 0.4, which is only slightly greater than topical placebo, by the way. So again, if you make the patient feel better, it really doesn't matter in the end. Okay, so rule number 3, and this is an important rule and gives you some permission to do things in resource poor environments, and that is there are no vital organs involved in joint injections. Okay, so unlike a paracentesis or a thoracentesis, or God forbid, a pericardiocentesis, there are no really vital bits that you can hurt by doing this injection. Okay, there are some risks involved, but they're relatively minor and they're easily abated. So I was going to show you a picture of a depot nitroviral showing a suspension, but I didn't do that. All right, so one of the things that is a risk, of course, is infection. There's various different studies which cite different risks. The one that I cite to patients is about 1 in 50,000. Some people have suggested this could be higher. I've stopped spitting on the needles for lubrication, and so my rates have gone way down. Pain, of course, is another problem, particularly with less skilled performers. And this can be mitigated with practice and with certain techniques, and I'll show you a few as we go. Hyperglycemia when you're doing steroid injections, particularly in poorly controlled diabetics. Show you a little bit of that data. A post-injection flare, and a post-injection flare is important to know about and to warn the patient about. Soft tissue atrophy. And then I'm not going to talk much about this one, but a foreign body synovitis. So when you go through a rubber stopper to draw up xylocaine or lidocaine or steroids, you actually get a tremendous amount of little rubber bits onto the end of your needle. And when you inject it into a location like a synovial joint, it can cause its own form of synovitis as it responds as the synovium responds to the rubber particles. So you do need to, once you've drawn up your xylocaine or steroid, you need to change your needle over to a fresh needle to avoid putting those in. Uh-oh. Why is my slide is frozen here? There we go. Okay, so this is the risk for hyperglycemia. This was a small study looking at about 17 patients with a range of blood sugar controls. About half of them had an A1C that was greater than 7. What I want to show you from this is a couple of things. One is that in the patients who got steroid injections, they did have a change in their fasting blood glucose levels for anywhere from 3 to 8 days after the injection, and that was here. When they separated them into those who were using insulin and those who weren't, or those who had poor control and those who didn't, the ones who had worse diabetes control or were on insulin had higher levels of glucose after an injection. They did use 80 milligrams of methylprednisolone injected into the subacromial space. I think it's important to know that when they actually compared this with smaller doses, like 40 milligrams, there wasn't any difference in effectiveness. So it's important to use the smallest dose that you can, particularly in patients who have diabetes. I use 40 milligrams maximum of dipomedrol or triamcinolone in a given joint, even a large joint like a knee. You really don't get any more bang for your buck by going higher. Some of the videos that I've referenced use 60 or 80 milligrams, and I'm pretty sure you don't need that much. You could also, if you need to do 5 or 10 injections, that happens in rheumatology sometimes, we could spread them out over a number of days to reduce the effect of that as well. This picture shows some soft tissue atrophy from a lateral epicondyle injection. And when you inject them into the fat or the soft tissue, it can result in atrophy or hypopigmentation. This is more likely with triamcinolone than with dipomedrol. So for soft tissue injections like bursa and tendon sheaths, we tend to use dipomedrol. For going intra-articular, where we're fairly confident where we are, we'll tend to use triamcinolone. This can resolve within about a year, but it can be a little bit disfiguring for some time. Okay, so pain reduction is always a problem, and when you're in rheumatology clinic and we're talking to people who've had their joints injected or aspirated in the emergency room, they often have a look of fear and post-traumatic stress disorder to them. And it's really just because of a few small techniques to reduce the amount of pain that people have. First, you need to remember that the pain-sensitive structures around a joint are the skin, capsule, and the periosteum if you happen to hit it. And it really doesn't matter if you happen to hit the periosteum. We use a small needle, a 25 gauge, 1.5-inch needle for freezing and simple injections. These are found in a lot of emergency rooms and in rheumatology clinics, but not elsewhere. And for injections, we usually mix the lidocaine with steroid together, and we only do a single injection because it hurts more to actually freeze than it does to do the injection itself. And then for aspiration, you want to freeze it really well, particularly the skin and the capsule. And so we put, for most joints when I'm doing an aspiration, I'll put a full 5 cc's of xylocaine. I'll infiltrate as I go in, mostly into the skin and capsule. I put about a cc of that into the joint itself and then put the rest into the skin and capsule on my way back. The other thing that is helpful, and this is actually in the pediatric pain clinic that I got this from, is that with little kids, when you're doing vaccinations, you can distract them by getting them to blow bubbles. I never remember to bring my bubble wand to clinic, but I just tell people about it and they laugh. If you get them to take a deep breath and pretend that they're blowing bubbles while you're doing it, it actually makes the whole process a lot easier. Okay, so the other thing that can happen with injections that you need to be aware of is a post-injection flare. So dipomedrol and triamcinolone are suspensions that get taken up by the synovium. And so the crystals that are in them can actually precipitate a gout-like reaction in the first few hours. This happens about 1 in 100 times. It is exquisitely painful when it occurs. You need to warn your patient about it, or they'll think you're a bad doctor. Um, and it's easy to distinguish from an infection that you may have introduced because infections usually happen a day or many days later, whereas this happens within the first few hours after patient has gone home. NSAIDs are extremely helpful, like they would be for gout. Ice is also very helpful that they can put on and off if they can't use NSAIDs. So we'll go over a little bit of the technique, just very briefly, for aspiration and injection. There's a number of different resources available on YouTube to how you do a particular one. One that's been endorsed by the Canadian Rheumatology Association is from a bright young guy in McMaster, Raj Carmona, and I'll show a couple of screenshots from his stuff. I don't agree with everything the way he does it, but they're clear videos with some nice anatomy on them to help you with it. And when you're going to go and say, I really need to aspirate this knee, then you can take a look at those videos and use some of the hacks that I've given you as well. So there's a few hacks that make life a little bit easier. First, freeze well with a 25 gauge needle if you're going to aspirate. And wait. You know, when we have a tendency in medicine to freeze with the right hand, and before the freezing needle is even out of the skin, to go in with the bone marrow biopsy needle or whatever else we're using. So whereas you go to the dentist, they freeze you, they walk away, they go somewhere else, they come back after they've had their coffee. So you want to give it a little bit of time to take effect. You need to use a 19 gauge needle or bigger for aspiration. I showed you the picture of those rice bodies. They can easily plug your needle when you're trying to aspirate a joint. And you want to make sure that you're getting some fluid out. When you're freezing with the 25 gauge, you can try withdrawing when you think you're in the joint to see if you get any fluid out. Probably about 2/3 of the time, some fluid will flow. But the rest of the time, it's too viscous and too clogged with things to come easily out unless you're using a big enough needle. Now, because there's no vital organs, you don't need to have, back pressure like you're doing when you do a thoracentesis or something like that, where you just want the bevel of the needle in the space. You can go right into the joint and then you pull out. I find that when I have back pressure and are pulling on the plunger when I'm going in, I don't know where the end of the needle is, and so um, it's a little less secure of a procedure for me. And then once you're in the joint space, you want to just pull on that plunger very gently. So one of the phenomena that happens a lot when you go into a joint with a great big effusion is that you go in and you haul on the syringe, and the first thing that happens is you pull in some redundant synovium and it plugs the needle up so that you can't get any fluid out. Sometimes you even detach the syringe from the needle and synovial fluid pours out of the needle, and then you just can't get it back out. So you got to be a little bit careful as to how that works. And then you want to use, even if you've got a very large effusion, you want to try using a small syringe like a 20 cc, because the bigger the syringe, the more suction is going to be at the end of that fixed 19 gauge needle. Okay, so for knees, I'll show you a couple of landmarks. If you're doing an aspiration, you want the knee extended. Okay, these are a couple of screenshots from Raj's tutorial. And the reason that we want the knee as extended as possible is that there's not a lot of room in the knee in this position, and all of the synovial fluid is pushed up underneath the patella, so it's easy to find. We go at the 2/3, sorry, the junction between the upper and middle third of the patella, and there's a little hole here, a nice little soft divot that you can usually blot some fluid in, that you would just go in following the line of the patella, which has a little bit of an angle to it. You can do a medial approach or a lateral approach. I tend to prefer the medial one, but whichever one thinks it gives you the biggest amount of space. For an injection, you can't see it as well from this angle, but this patient is sitting on the plinth with their knee at 90 degrees. And the reason we do this one is that you don't actually have to get the patient up on the exam table. Most of you work in environments where the exam table is not motorized. And if you try and get people with bad arthritis up onto those benches, you're really asking for an orthopedic or a neurosurgery consult when they fall off. So you can do it while they're sitting in the chair without too much difficulty. And what you're looking for is the top of the tibial plateau, which is outlined here with pen. Here's the patellar tendon, and there's a nice spot in between here and the femur that will allow you to go in at a straight angle to find the joint space very easily from either side. So this is a very simple procedure to do and can be done very quickly. Okay, I couldn't find exactly the picture I wanted for the shoulder, but I'll walk you through this one a little bit. And again, there are lots of videos out there. So if you're doing a subacromial injection and you want the supraspinatus tendon or the subacromial bursa, then you're going to go up and underneath the acromion. One of the main landmarks to find, and I encourage you to find it on yourself and any of your close friends tomorrow morning, is the sort of what I call the corner of the shoulder or the angle of the acromion. If you follow the spine of the scapula until it turns to become the acromion, this corner here, usually there's a nice little divot underneath, and you can go in and you can see how the needle is angled up and under the acromion. So there's a nice little soft spot there. If you want to inject the glenohumeral joint in patients with bad osteoarthritis or rheumatoid arthritis of the glenohumeral joint, you can go a centimeter below that, and then you're going to aim for the coracoid process, which is hiding over here on the other side. A little harder to see on that view. Okay, so where are we here? Running just about on time. So rule number 2. And these seem a little sillier as they go, but rule number 2, the second most important thing you'll know is that Band-Aids don't stick to chlorhexidine. Okay, so you got to put a Band-Aid on later. If you used chlorhexidine to prep your thing, you need to wipe it off before you can do that. And the reason I have this as my number 2 is that really to talk about the principle, the joints are not the same as intramuscular or soft tissue injections. Joints have a unique immunology due to the synovium, which is why they get so involved in rheumatoid arthritis and other things. If you're injecting a damaged joint, which mostly we are, otherwise if they're not damaged, we wouldn't be putting a needle in there. They're more susceptible to infection. So if you get a bacteremic infection, if you're going to seed one of your knees, it's going to be the one that has osteoarthritis. Joints have a potential space. So if you do get an infection there, it becomes like an undrained abscess that becomes very hard to treat unless you drain that area. And if you're injecting steroids, you can often mask the immediate signs of an infection for a week or more while this percolates around and destroys the joint. So the consequences of an intra-articular infection are pretty high. Joint damage, prolonged antibiotic courses, and possibly a surgical procedure for incision and drainage. Now I'm going to show you a little bit of a data-free zone. There's a wide variety of skin prep that's used for procedures. Given the rarity of infection, there's been very little systematic data on best practice, but I would highly recommend that alcohol swabs are not enough if you're going into a joint space to clean the skin. Alcohol works very quickly. It's pretty good for gram positives, but it doesn't work for gram negatives, and it's got a lot of deficits. Chlorhexidine and povidone are much better skin sterilizers, which is why we use them for most of the other procedures. So I would highly recommend that you use those when you're doing intra-articular therapies. And I prefer chlorhexidine to povidone because it's a whole lot cleaner and looks good, except Band-Aids don't stick to it. Okay, now I've been teaching residents and medical students and trainees how to do joint injections for a long time. And over the last, I don't know, several years, I have, when I've had the residents in a room with the patients, and we're doing the injection and we're finished the injection, and I almost always stop and I say, so the second most important thing you're going to learn in rheumatology is that Band-Aids don't stick to chlorhexidine. And even though I've done this probably with 40 or 50 residents over the last several years, not a single one of them has surprised me and asked me what the most important thing they're going to learn in rheumatology is, even though I wait a long time to find out if they're going to ask. So I'm hoping that that was the first question that came to your mind when I said this was rule number 2, and you've been dying to hear what rule number 1 is. So with a drum roll, rule number 1 is that nothing at all destroys the confidence of the patient and the doctor more than if you put on a Band-Aid and it falls off right away. And with that, I will stop and answer some questions.
I have a question.
Yes.
Regarding the hip injections, it's most difficult, isn't it?
Which one? The hip injection?
Yeah.
Yeah, so
hip and the steroids in the hip.
yeah, so hip injections are tricky. They really need to be done under guidance. So I didn't talk about ultrasound or fluoroscopy. Um, for most of the injections that we would think about, that you can do them blindly, but you really can't do hip injections blindly. So we get them done under fluoro, and then see if that does the trick. So we would get the radiology to do them. Some of the sports medicine guys who are facile with ultrasound will be able to do ultrasound guided ones. I'm not 100% familiar with ultrasound of the hip to know how good that is. Other injections that are hard to do blindly would be subtalar injections, SI injections, of course, spinal injections. So, but yeah, I wouldn't even try a hip blind because I think you just don't know where you are.
No, because I have a patient, he had intra-articular hip injection in the right, and now he's insisting he wants the injection in the hip because of osteoarthritic pain, and I'm not sure where exactly should I refer him, because we are in rural settings, like sometimes it's difficult the referral. So who will be the easiest person can I can consult or he can go to?
I send all mine just to central intake for diagnostic imaging, and usually for my patients, even the ones who are from out of town, they will get done either at St. B or Health Science Center. One of the musculoskeletal guys be happy to do those. They take about a month to get booked, but they're pretty good.
Okay. Thank you.
I have a
Have
question.
a,
Sorry.
okay, go ahead. You can go ahead.
Dr. Tala. So first of all, what a wonderful lecture. Thank you so much. I did posted my question in chat. So I was just worried, saying that Can we do the aspiration and joint cortisol injection at the same time? Like, for example, in gout, we take out the fluid and send to the lab, and then as soon as we take it out, and then we inject steroid to make the patient relief.
Yeah, so if sometimes if you are pretty sure that this is just a gout attack, for example, or even just a flare of rheumatoid arthritis, you can aspirate. And unless you get cream of mushroom soup, those ones that I showed you that are frankly purulent, and you feel confident that this is really just a gout attack, then you can put the steroid in. It's always helpful because you've got the fluid percolating. So a culture, if it is infected, is going to come back positive in the next 24, 48 hours, and in which case then you can get the patient on to antibiotics. So we often will do that in order to save time. You can use the same 19 gauge needle. You just detach the syringe from it, from the needle, leave the needle in place, and then you can inject the steroids through there. So yeah, absolutely.
So before Dr. Dalla, can I ask a quick one more question too? So is there any evidence of intra-articular antibiotic injection for having septic arthritis or something like that?
Yeah, so the ortho guys, when the patients have septic arthritis, will wash out the joint with copious amounts of saline under sterile conditions, but they usually don't put in any antibiotics to instill in it. I think it probably has been tried and probably didn't work. So intravenous antibiotics, most synovial fluid is a distillate of your blood anyway, and so if you do good source control, which is to get the fluid out of the joint, then the IV antibiotics will do the trick. And putting the antibiotics into the joint is not going to, I wouldn't even know how much to put in, and whether it would cause any chondrocyte damage or that sort of thing. But I'm sure people have tried it. I just don't know the literature around it.
Thank you.
Thank you so much, Dr. Robinson, for this wonderful session. Just a quick question for let's say somebody with a bad knee osteoarthritis waiting for knee replacement. How often, like how frequent can he get the intra-articular cortisol injection?
Oh, that's a good question. So, we've all sort of seen the folks who are hobbling around, and you inject their knee and they get better. And then it's like, okay, when can I do this again? And I actually meant to put this into my talk, and somehow it fell off. So thanks for asking. So you can do it. We usually tell patients about every 3 months they can have it done. The one thing about these injections is that when you're doing them for OA, over time they tend to work less well as the arthritis gets worse and they get closer to needing an injection. So there's a few elders in some of the communities who show up before I do at the clinic on the days when I'm coming, because they know I'm coming and they want their knees injected and they want it now. And we don't even send them necessarily for orthopedics because they get a good 3 months worth of benefit out of it. When that starts to work a little bit less, then we'll get them in line for an arthroplasty. And for some of the ones that are really not doing well, as long as they get a month's worth of benefit out of it, then I'll continue to inject them. But I try not to inject them any more frequent than 2 months. And that's usually just, in the last 6 months before their surgery, because it's really, most of them are diabetic and they get a little hyperglycemic and whatnot. From the flip side of that is how close to a surgery can you do an injection? And the vast majority of the orthopedic surgeons, although the data is not all that great, would not want you to do an injection within 3 months of their surgery date. So if they have a surgery date that's within 3 months, then you just got to get the patient to suck it up for that period of time. And they're pretty good. Once they have their surgery date, generally they're pretty happy to sort of wait and not have any more complications there.
Yeah, sounds good. Thank you so much.
There's a question on the chat here. How do we approach high serum uric acids with unremarkable physical signs? I assume that means how to uric acid that's there, but you don't have any gout at all yet. There's a little bit of controversy around that, and I think the pendulum goes back and forth as to whether these things should be treated. Some people felt that these were markers of cardiovascular disease and metabolic syndrome, and that you should probably treat it, even though it's asymptomatic hyperuricemia. I think the pendulum is shifting back a little bit in that we probably don't need to treat it. Extremely high levels of uric acid in the absence of joint inflammation, joint damage, or kidney stones probably doesn't need treating at this point. But very high levels of uric acid will eventually lead to that. And so you just have to keep an open mind around it. The second question on the chat here is if there's no gout attacks, but there's a high blood level uric acid, at what point do you start the patient on? Okay, yeah. So very similar prophylactic medication, very similar question. And I probably wouldn't, the key indicators for starting hyperuricemic therapy is a frequent or difficult to treat uric gout attacks, joint damage. Occasionally you'll see people who actually have typical urate erosions on X-ray, but swear up and down that they've never had an attack. Tophi, so if there's tophi on the skin, and then the third or the last one is nephrolithiasis, so if they've had uric acid kidney stones.
Okay, it seems there is no more question. Thank you for your time again, and very informative session. Much appreciated.
All right, you're welcome. Thanks very much, guys.
Take care.
Thank you so much. It was very good.
Thank you. It was an awesome presentation.
Thanks very much.